I was diagnosed with PBC at the age of 59. My only symptom was fatigue, and I believe I'd had PBC for many years before my diagnosis. I was very sick when I started my journey 9 years ago, and in those early days I was highly motivated to stave off my feelings of anger, fear, and hopelessness. So I decided to join a community dragon boating team. Eventually, I was invited to join a competitive team, and I trained for 10 months of the year for 6 years. I did CrossFit, weightlifting, paddle erg classes, attended dragon boat camps, and took part in many racing events, including the World Championships in Hungary. I ended my dragon boating days before the pandemic on a trip to Tobago for extreme dragon boat racing on the ocean. It was physically grueling and tested every muscle in my body. And I literally fought for my life on those boats. But here's what I've learned from all my experiences about how to survive the storm that is life after finding out we have PBC. I've discovered that the mind-body duality is an amazing force, that we can be tested and still keep going. I've also learned that fear can be a motivating force, frustration can move mountains, and we need to empower ourselves. I'm grateful to my specialists who have been able to monitor and treat my liver disease, assess my response to URSO, and recommend second-line therapies along the way. Thanks to them, I can remain focused on making sure that I am empowered to lead my best life. And this is why I have the pleasure of introducing our next speaker, Dr. Aliya Gulamhusein, who will talk to us about how PBC patient care must maintain a balance between treating the liver and maintaining our quality of life.
Good afternoon, everyone, and thank you for that lovely introduction. It was really some beautiful words. So I've been tasked with the challenge of discussing a balance between the quality of life and quantity of life in patients with PBC. Oh, that's the wrong way. So let's start with some definitions. So what does quality of life mean? So this is a definition from the WHO that defines quality of life as an individual's perception of their position in the life in the context of the culture and value systems in which they live, and in relation to their goals, expectations, standards, and concerns. And I've highlighted a few parts of that phrase which I think are important. This is an individual's perception, what they feel, and thinking about your cultures and your culture and value systems and how that is important as it relates to your health. The quantity of life is so much simpler. It's much more formulaic, right? The number of years you live. These are two vastly different concepts that I think is very important for all physicians and all patients to consider in their interactions. When I'm in the clinic, I oftentimes talk to our fellows about thinking about, if not frankly discussing it, but thinking about a patient's philosophy of care. This is unique to individual patients and is really vital to incorporate into management in a day-to-day manner. It's our responsibility to consider what are patients' values and priorities, what is their vision for the future, and at some times, what are their end-of-life wishes. If we don't think about that and we don't open those lines of discussion, they will never be discussed, because as physicians, we're trained to sort of treat numbers, treat pictures, treat images, but it's so important to consider these things that make an individual unique. This is a really important upfront conversation, and I try to encourage all the fellows and students that rotate through our clinics to consider this. The doctor-patient relationship is more than just prescriptions. It's more than just appointments. It's more than just see you 2 times a year, 3 times a year, 1 time a year. It's important to consider all these factors that are listed in this figure: shared beliefs, have compassion, be present in that appointment, whether it be 15 minutes, 5 minutes, or an hour. Being present is really important. mutual respect, knowledge and experience, affordability, the opportunity to learn from each other, having trust and confidentiality, knowing that that appointment or that interaction is confidential and that you can trust your provider, and that they will be honest and have integrity in discussing with you. All of these things are really, really important to consider and to incorporate into the doctor-patient relationship. So PBC disease burden is complex. Physicians who treat a lot of PBC know this and see this every single day, but it's clear to patients and us that severity and symptoms are different. It's often like this fork in the road. They're not always aligned. Like it says here, disease severity and symptoms don't always align. Disease severity is objective. It's defined. It's much easier to see on a screen or on a piece of paper. The treatments are clear and effective. Many patients with PBC are entirely asymptomatic, so the severity is often something people don't feel. But the severity can be impactful on symptoms, oftentimes towards the late stages of disease when complications of liver insufficiency are occurring. Symptom burden is much more subjective and much more poorly defined. We struggle because treatments are historically less effective, but we know that this is highly impactful on quality of life. And we heard this yesterday and a few times today, that physicians are poor at talking about this because we struggle with treating it. But this is really, really important to all of you. And more we're learning that, and we know that the patients care about this as much, if not more, than what the numbers say. This is not new to any of you, but PBC is a disease, is an autoimmune condition that leads to chronic inflammation and cholestasis within the liver, and that inflammation can progress to fibrosis or scarring, and ultimately this can end up with cirrhosis and end-stage liver disease. It certainly doesn't do that in everybody, but the symptoms of disease severity often happen towards these end stages. Like I said, doctors are often better at addressing quantity of life. We're good at looking at numbers and saying, you know what, this disease is severe, and we're good at looking at curves like this and saying that this patient has PBC, we've diagnosed that condition, here's the treatment that we have, and they respond or they don't respond to ursodeoxycholic acid based on what their numbers look like. The treatments address the quantity of life. We're good at assessing patients' risk, and more over the course of the last few years, maybe 5 or 10 years, we've become more specific about different factors that are associated with the risk of progression. It's not just what your blood tests look like, but a patient's age at diagnosis, what their biochemical response to URSO is important, what their fibrosis stages, be that on biopsy or with a FibroScan. Those are all factors that can impact characterization of risk in PBC. And while this is becoming more complex, it's still an objective feature of disease. Disease severity, once we've defined it, we decide on treatment. So URSO, we know, improves liver transplant-free survival among patients with PBC, and you can see that, like I said, we're good at looking at these curves. Patients who are treated with URSO do better than those who are not treated with URSO, whether or not they respond to therapy. We know that when we treat, patients will do better, and we hope that that's the case. And this concept of surrogates has evolved, and that's really helped us develop second-line, third-line combination therapies to treat, again, these objective features of disease severity. So this is data from the Global PBC Study Group that identified really good surrogates of outcome, the alkaline phosphatase and the bilirubin, that are strong predictors of how a patient will do, how long they may live. But again, they're blood tests, right? They're numbers that we can see on a piece of paper and don't reflect oftentimes the patient sitting in front of us. It's easy to teach fellows, residents, students to treat numbers. Look at a blood test and say, this is what I need, this is what the next step is. Diagnose PBC, a patient has a positive AMA, they have an elevated ALP, start them on URSO, see what their blood tests look like after 6 months, after a year, start them on another drug and add and add and add. And that part's easy, that's an algorithm. But more, like we'll talk about in the coming slides, more and more, it's not just treating the number, it's treating the person in front of us. And that's how it should be. It should have always been. But you can see here that even the way we're treating is different. This is data that was published more recently that shows that we were looking at the ALP, how much it improved to a certain threshold. Maybe your ALP should be 2 times the upper limit of normal, and that's a good response. Maybe it should go down to 1.67 times the upper limit of normal, and that's a good response. But now more and more we're saying maybe your numbers should be normal, and that's the best outcome. But again, that's just treating the numbers. We do this, and because of all this data that we've accumulated that tell us about surrogates of outcome, tell us about disease risk, and because of the new drugs that are available, we're more inclined to look at those numbers closely. We're doing that more and more often, and looking at disease severity to see whether we can improve outcomes with these second-line agents that are available. So the first that was the only licensed drug that's available as a second-line therapy, as many of you will know, and the first that came on the market was obeticholic acid. And this is data that looks at the global PBC study group and the UK PBC study group that show that the patients that are treated with obeticholic acid, high-risk patients that are treated with obeticholic acid, do better than those that are not treated with a second-line drug. Similar data for bezafibrate, which is a PPAR agonist that some of you may or may not be on, but this data shows, again, these curves that separate. The patients that are treated with bezafibrate with high-risk disease do better than those that are not treated with bezafibrate if their blood tests remain elevated. New drugs are becoming available, so we only have one licensed therapy now. We have off-label therapies now, but we will have more drugs that are really good at what they do. So this is data from seladelpar, which some of you may have been involved in the studies that are looking at this agent, that just looked at 3-month data that shows that, you know what, numbers improve, but this is the transition to drugs that not only help numbers, but help symptoms. So in the figure on the right, you can see that, that there were significant improvements in pruritus or itch in patients that were treated with this drug. Like I said, we look at patients when they come to the clinic and we assess for disease severity all the time, but the drugs that treat disease severity don't often tackle symptoms. And you know this much better than any of us, but there are common symptoms in PBC. These include, but are not limited to, pruritus, fatigue, right upper quadrant discomfort, the Sicca complex or dry eyes and dry mouth. And in the late stages, manifestations of liver dysfunction like jaundice, ankle swelling, ascites, varices, those things can develop. Without question, quality of life is impacted in patients with PBC. Not in all patients, but in a significant proportion of patients with PBC. And this is data from a while ago that used quality of life questionnaires, the PBC 40, to show that patients with PBC have significant impacts in fatigue, in cognitive function, in emotional function, in the social domain, in many domains of function. And this is interesting data that was published out of the CANAL data set that looked at the differences in quality of life using different questionnaires. This is the SF36 in patients of different backgrounds, of different ethnic backgrounds. So Caucasian patients versus Asian patients versus Indigenous patients. Patients have different experiences. That's I go back to the first, the definition of quality of life. It takes into account cultures, values, a patient's experience. And so that experience is not the same in someone of an Indigenous background and someone of an Asian background. We need to incorporate these things when we're thinking about patient care. And this is just a different way of showing that. It's sort of a fancy figure that shows that the different domains of the PBC 40, the emotional domain, the social domain, the itch, fatigue, symptom domain, those individual domains can be different in patients of different ethnic backgrounds as well. Like I said initially, symptoms are poorly talked about in the clinic, unfortunately, because I think at least because they're oftentimes very difficult to treat. But first and foremost, that doesn't mean that they shouldn't be discussed. PBC patients are amongst the best advocates for their health that I know. And so I encourage you to make sure that this is a talking point with your physician if it's not brought up with you, which I hope it is more often than not. I'll spend most of the time, and if the next few slides at least, talking about pruritus, because this is sort of a flaw of my own, but because we have treatments for pruritus that should be available to you. And the other symptoms that do impact quality of life, things like fatigue, which is probably the most impactful symptom, sicca, pain, myalgias, those remain a real challenge to treat. But there are drugs in the pipeline that hopefully will be able to address these soon. But pruritus is a challenge to treat, but treatments are improving. What does cholestatic itch mean? What does it present as? So it has a characteristic diurnal variation in intensity, which means it's different at different times in the day. Oftentimes patients describe it being the worst in the evening or at night. It can affect the palms of the hands and the soles of the feet, or it can be generalized. And it can be exacerbated by other things like psychological stress, the physical environment like heat or contact with certain materials. And I really love Dr. Tandon's talk that reminds me every time that there are non-pharmacologic approaches to care and there are pharmacologic approaches to care, and we have to incorporate both of those things. And psychological stressors really do impact symptoms. Oftentimes this itch is not relieved by scratch, and patients tell me that over and over again. And usually there's no primary skin lesion, and that's pretty characteristic, that it's not a rash that's itchy. It's an itch that can lead to rash because you've sort of broken down the skin, or you have excoriations, but it's generally not a primary rash. There are treatment options, and it kills me when patients come to the clinic and say that they've been itchy for years to the point where they can't function, but they've never been offered one therapy or two therapies or a stepwise approach to therapy. So this is just an example of drugs that are available for treatment. The first drug that's tried is cholestyramine or Questran, which is a bile acid resin, which sort of decreases absorption of bile acids. There are other agents that aren't used as frequently or probably underutilized, things like rifampicin, naltrexone, sertraline, even other drugs called gabapentin. Those drugs are available for use, and they need to be used in a slow, stepwise manner so that you know what works and what doesn't. Not every drug is going to work for every person, and you just need to figure out what's best for you. But there are several options for drugs that are available and that will become increasingly more available to treat itch that hopefully do improve quality of life. So the fibrates are a class of drugs that were studied in this FITCH trial that was a randomized placebo-controlled trial in patients with moderate to severe itch and weren't limited to PBC, but cholestatic disease, including PSC and secondary sclerosing cholangitis. And bezafibrate was used and showed a significant improvement in itch across the board in all diseases. Seladelpar, I mentioned earlier, is a drug currently in development that will hopefully be available for patients in the not too distant future, but was also studied for not only disease severity, but also improvement in symptoms, particularly itch, and also showed a significant improvement in itch over time. Another class of drugs, one called the IBATs, maralixibat, was studied in patients with PBC a few years ago and was actually a negative study. And some people would say, oh, this doesn't work in PBC then, but it's important to really understand, for physicians to really understand the study and understand where it was successful and where it struggled. And this looked like it was an unsuccessful or a negative study, but it was actually because patients who were treated with placebo had an improvement in itch. So the difference between those that were treated with drug and placebo was not significant, but itch did improve in patients who were treated with this agent. So it's hopeful that agents like this will also become available for patients with PBC. So I mentioned that I wasn't going to talk about the other symptoms that impact quality of life, which certainly there are, particularly fatigue and pain. And like I said, it's because that there's not many effective therapies for these, but these things have been addressed in previous talks. But just for take-home points, I'd like to emphasize these things that we all know but should keep at the top of our head, that PBC is complex and it's becoming increasingly complex. Disease severity and impact, particularly quality of life, should be regularly assessed by patients and their physicians. Symptoms often impact quality of life and are difficult to treat, but doesn't mean they should not be treated or not be discussed. Fatigue and itch are common symptoms. There are promising treatments for disease severity that are available and for pruritus and others, even fatigue, that are in development. But open lines of communication with physicians about your philosophy of care are vital at all stages of disease. Thank you very much.